We will be having this recorded today. So if you have to leave early, we'll have this recorded and you can always watch it again. When you do watch a recording, just as a reminder, you do not earn CEs through a recording. But those of you that are here today, we will be earning 2 CE credits that are approved through NADAC and NBCC. I'll get to that more in a moment. But first, I want to welcome Rhonda and Megan. Rhonda is our Corporate Director of Clinical Services, and Megan is the Regional Manager of Utilization Review, both working here at Promises. So if you attended our treatment planning webinar a few months ago with Jamise, this is a great follow-up to that. If you didn't catch that one, it is recorded on YouTube. So give that a look if you haven't watched that one. That one I know is great. Today, we're going to talk about integrating ASAM in person-centered documentation and treatment planning. Megan, you can click to the next slide for me. So just as a reminder, Promises Behavioral Health, we have a growing number of residential services across the country. You'll notice this has been updated. So now we actually are offering very soon a Promises Dallas Fort Worth. So I'm very excited to be growing our locations in Texas and Tennessee, Ranch, Tennessee, just outside of Nashville. That's our flagship location. All of our locations really prioritize our clinical confidence. So we do these webinars not only just for you all, but to really highlight our expertise that are working within our communities, within our clients, and always focusing on trauma-informed care and truly looking at our treatment outcomes. And you all are a part of that and understanding why that's so important. So if you'd like to learn more about Promises, you can go to promises.com. We have a family services page that I highly recommend checking out as well. And if you have any questions or want to learn more about any of our facilities or locations, you can email me at callie.boyer@promises.com or pbhu@promises.com. You can go to the next slide. Okay, so for the CE process, if you've been to a training recently in the past few months, it's pretty much the same. So to receive credit, I will say this many times, but you have to be here. You can't miss more than 5 minutes of the training. So if you're here right now, you're doing great. It's for anyone that joins us late that I usually have to email and say you have to be here for 90% of the training to earn your CE credits. If you are here and you registered through Zoom, then I have your email that works as your sign-in, so you don't need to send me that again. I've already got your email address. If you have a Yahoo email address, I do notice that those have a hard time receiving my surveys. So after the training, you'll receive an email from JotForm with the survey. If you have a Yahoo email address, if you don't receive that survey by the end of today, go ahead and reach out to me with a different email that I might be able to send that to. And for everyone, if you don't see that JotForm email by the end of the day, check your spam folders. And if you don't receive that survey by the end of the day, you could also be receiving a rejection email from me that just says you probably didn't meet that time requirement. So you'll either receive a survey or a rejection by the end of today. And then just know that I do have to close the survey. It says Wednesday, but it's actually next Friday is when I have to close the survey. So you have a week to fill out the survey. Please use the week and do it today if you can. And then once you fill out that survey, you'll immediately get a certificate through JotForm, kind of bounced back to your email. So you'll look for another email from then. It automatically creates your certificate for you right then. And then again, with our slides, the recording, other resources, that will come to you in a separate email next week. You can move on. Great. So during the webinar, it's pretty simple. So the chat box, those are questions for me. So if you have questions about your computer not working, audio, your CEs, just webinar functions, put those in the chat box. So that way I can just attend to those. And then the Q&A are questions for Megan and Rhonda regarding the content and questions you have for them. We will have a Q&A, a 5-minute break in the middle, and then a Q&A again at the end. So put your questions into the Q&A box. I will collect those and send them to them so they don't have to worry about the extra noise and questions that come through. So questions for Megan and Rhonda, put those in the Q&A at the bottom. Save the chat for questions for me. And that's it. If you want to take notes, feel free. We'll have this recording. You'll get this to you next week. So just enjoy. I think we're going to have a lot of great content today. Really happy you both are here. Upcoming trainings. So we are closing out the year, folks. November and December are our last two webinars of the year. We already have a really great list of content that we're pulling and planning on for next year already. So these webinars will continue in 2025. But for November and December, next month, we're back with Trish. If you joined us last month, she was the speaker then. And she'll be speaking about measurement-based care and skills to enhance recovery. If you haven't attended a webinar with Trish, I highly recommend it. She is our Senior Vice President of Clinical Operations and sort of leads the charge on all things clinical for Promises. And then finishing up with Wendy, who actually did speak earlier this year. She's our Director of Family Services. So if you are interested in family therapy and understanding the integrations of family with recovery, she's a wonderful speaker, and the power of family and connections in recovery is going to be a great one. So I will send those registration links to you all when I'm finished here in the chat, and then you can go ahead and sign up for those today. We can go to the next slide. Oh, that's it for me. Thank you both.
All right. So I'll go ahead and start by introducing myself. Like Hallie said, my name is Rhonda Stewart. I am the Corporate Clinical Director here at Promises. Really, really excited to be here today with all of you and share knowledge of ASAM and personalized treatment planning. I've been in the behavioral health field for probably over 20 years now. Spent some time in direct care. I've been in community-based, spent many years as a therapist myself. About 8 or 9 years as a clinical director at a residential facility. I'm an LPC. I have 2 sex offender certifications because I spent about probably a good 10 years also working specifically with sex offenders in residential and community-based groups. I'm really excited. Over the last 5 years, I've been in corporate level positions on clinical teams, and that's something I'm really passionate about. I've traveled nationwide working with clinical leaders on ensuring quality of care. So I'm going to talk a lot about that today and how important it is to really target the work we do in personalized treatment planning. So I've been doing that with Promises. I'm coming up on 1 year with Promises, and I'm really happy to be here today. Something that's also very passionate about mine is community based support. So I started a nonprofit back in 2021, and my nonprofit has fed thousands and thousands of families across my local area and beyond, even extending into other countries. So that is something I'm extremely passionate about. So yeah, I'm really happy to be here today and share with all of you. Turn it over to Megan.
Hi, everyone. My name is Megan Brandsteiner. I'm an RN. I have my BSN. I've been in this field of substance abuse and mental health for over 10 years. I started out at the bedside, transitioned to case management, director of nursing, as well as utilization review. And now I'm the regional manager of utilization review for Promises for the East Coast. So just like Rhonda, I'm very, very passionate about substance abuse and mental health. We will go ahead and get started. Okay, so for the objectives, we're going to take a deep dive into the ASAM, specifically the 4th edition. Developing personalized treatment plans, and then strategies for effective interdisciplinary collaboration, and then improving documentation practices. So what is the ASAM criteria? As of October 2023, the fourth edition has been released. Rhonda and I are excited to share this edition, which advances our field by incorporating strong evidence and addressing the needs of individualized addictions and co-occurring disorders, along with those of their families and broader communities. The ASAM criteria is a comprehensive set of evidence-based guidelines designed to assess and appropriately place individuals into the correct level of care for substance abuse and co-occurring conditions. This standardized framework ensures that care decisions are tailored to the individual's needs, prioritizing the least restrictive yet most effective level of care. At the core of the ASAM criteria is the 6-dimension framework, which is used to evaluate patients holistically, considering a wide range of factors. These dimensions guide treatment planning by helping clinicians assess not only the individual's substance use history, but also the medical, emotional, and environmental factors that can affect recovery. Each dimension is not looked at in isolation, but in relation to one another, giving a full picture of the patient's overall needs. This approach helps clinicians determine whether a patient would benefit from less restrictive setting like partial hospitalization, inpatient intensive outpatient programs, or if they require a more structured setting like 24 residential care. The ASAM criteria is not only used by clinicians, but also play a critical role in the payer's process, guiding decisions related to treatment authorization. Payers utilize these guidelines to evaluate whether the level of care recommended by clinicians is appropriate based on the document medical necessity. This standardization helps ensure that patients receive coverage for the appropriate level of care while also managing healthcare costs by avoiding over or under treatment. Additionally, the patient-centered focus of the ASAM means that treatment is adjusted based on ongoing assessments. This allows for dynamic, real-time changes in care as the patient's condition improves or worsens, ensuring that they receive the appropriate intensity of care. By using this comprehensive approach, the ASAM supports long-term recovery outcomes by making sure that every aspect of patient's health and situation is accounted for in treatment planning. The use of the standardized criteria also promotes consistency across treatment centers and payers, helping reduce variability in care delivery and ensuring that patients across different facilities receive the right care at the right time. Throughout this presentation, you will see the purpose and guiding principles, how they're incorporated throughout the treatment planning. So the primary purpose of ASAM is to provide a comprehensive standardized framework for assessing individuals with substance use disorders and co-occurring conditions. It guides clinicians in determining the most appropriate and individualized level of care needed for effective treatment. The criteria aim to individualize treatment, which will tailor treatment plans based on a thorough assessment of each person's unique clinical needs and circumstances. Determine appropriate level of care. You'll use the multidimensional approach to place individuals in the most suitable level of care, ranging from outpatient treatment to residential services or even inpatient settings. Ensure ongoing care and adjustments. You'll monitor and adjust treatment levels as the individual's need changes over time, promoting continuous assessment throughout the recovery process. Promote holistic care. You'll address not only substance use, but also co-occurring mental health disorders, biomedical conditions, and social factors that influence recovery outcomes. Improve treatment outcomes. Enhance patient outcomes by ensuring that treatment plans are evidence-based and targeted to the specific risk strengths, and challenges of the individual. The guiding principles. The ASAM is based on several guiding principles designed to ensure effective and individualized care. Holistic and biopsychosocial approach. Addiction is viewed as a chronic biopsychosocial disorder, which means that treatment must address biological, psychosocial, and social dimensions of the individual's life. Recovery requires attention to all 6 ASAM dimensions to ensure comprehensive care that looks beyond just substance abuse. Individualized person-centered care. Treatment is customized to the individual's specific needs, preferences, and circumstances, rather than applying a one-size-fits-all approach. The individual's unique strengths, readiness to change, and personal goals are central to creating an effective treatment plan. Continuum of care. The ASAM criteria provides a structured continuum of care levels from early intervention to medically managed intensive inpatient services. The principles ensure that patients can move along the spectrum of care based on their changing needs, offering flexibility and ensuring they receive the right care at the right time. Ongoing assessment and flexibility. Treatment plans are reevaluated and adjusted as the individual's situation, risk, and needs evolve during the recovery process. Dynamic assessment allows for increasing or decreasing the level of care based on the clinical progress. Multidimensional assessment. The ASAM criteria emphasizes evaluating the individual across 6 dimensions rather than focusing solely on substance use. This includes medical, emotional, cognitive, readiness to change, relapse risk, and the recovery environment. The multidimensional approach ensures that all factors influencing addiction, recovery are considered in treatment planning. Evidence-based and outcomes-driven. The criteria encourages the use of evidence-based practices and treatments that are supported by scientific research. The treatment outcomes are monitored on a regular basis to ensure effectiveness, and adjustments are made to improve success rate. Engagement in treatment. ASAM emphasizes that individuals should actively participate in their own treatment and recovery process. Motivational interviewing and other strategies are used to enhance an individual's commitment to recovery and promote sustained behavioral changes. Rhonda will take a deeper dive into these strategies during her portion of the presentation. So now, what's new in ASAM 4th edition? One of the key changes is the introduction of Dimension 6, which is person-centered considerations, which replaces readiness to change. This reflects the growing emphasis on addressing social determinants of health and ensuring the treatment plans are tailored to individual needs. While readiness is still an essential factor, it does not independently contribute to the level of care recommendations. As such, this dimension was removed, and readiness is now considered within each and every dimension. There is also an effort to simplify terminology and make assessments easier for clinicians. With these updates, ASAM criteria better align with modern, holistic approaches to addiction care. We'll take a deeper dive into each dimension, but first I would like to go over some key terms. Within each dimension, there are subdimensions, drivers, and influencing factors. And again, when I go over these, Rhonda is going to take that much deeper dive in incorporating each of them into the treatment planning process. A subdimension refers to the specific aspect or components within each of the ASAM dimensions. These break down the dimension into more focused areas of assessment, offering a closer look at the patient's condition. Subdimensions provide clarity on what clinicians need to evaluate within each dimension, ensuring that all relevant factors are considered. Drivers are the underlying causes of or key factors that push or pull a patient's condition within that specific dimension. Drivers are elements that significantly influence a patient's risk level, treatment needs, and overall prognosis and recovery. Drivers guide clinicians in understanding the primary focuses impacting the patient's health and treatment progression. Influencing factors are broader elements that shape how a patient's respond to treatment and recovery within each ASAM dimension. These factors may come from various areas such as individual's environment, social supports, personal beliefs, or life circumstances. Influencing factors help clinicians tailor their treatment plans to account for unique variables in a patient's life that could enhance or hinder recovery. By considering subdimensions, drivers, and influencing factors, clinicians can ensure that they are taking a comprehensive, individualized approach to care, addressing not just the substance use, but the broader context of the patient's life. Throughout this presentation, you'll hear Rhonda and I mention patient-centered and individualized care multiple times. That is very important when developing that treatment plan. So now we're going to get into each dimension. Dimension 1, this is acute intoxication and withdrawal potential. This dimension evaluates the individual's current level of intoxication and their risk for withdrawal symptoms. It plays a crucial role in determining whether detoxification services are necessary and the appropriate intensity of care required to manage those withdrawal symptoms safely. The primary focus is on ensuring that the individual's immediate medical needs are addressed, including monitoring for complications from the intoxication or withdrawal. So the subdimensions for this dimension would be types of substance involved, severity and history of withdrawal, medical stability and need for monitoring, the drivers, biological, environmental, and situational influences on intoxication and withdrawal. Influencing factors, the individual's history of tolerance and physical dependence, age and general health, previous withdrawal experiences and access to medical support, need for medication management or medical interventions. Common standardized measures used to assess withdrawal risk include CWAS, COWS. These assessments help clinicians gauge the severity of withdrawal symptoms, which in turn informs decisions about the level of care. Payers are primarily concerned with whether the patient is currently experiencing significant withdrawal symptoms or is at risk of acute intoxication. They look for evidence that individual requires ongoing monitoring, medical intervention, or detoxification services. Additional treatment days are more likely to be approved if the patient is in need of continued detoxification support, such as managing severe withdrawal symptoms, or if there is a clear risk of medical complications related to acute intoxication. In some cases, detox medications such as Suboxone may be required to manage those withdrawal symptoms or reduce cravings, such as naltrexone. The use of these medications can affect the type of duration of treatment, as their administration often requires medical oversight. The presence of co-occurring medical conditions such as liver disease or heart problems can also complicate withdrawal and may lead to the need of extended care. Dimension 2, biomedical conditions. Dimension 2 assesses any existing medical conditions or physical health issues that may complicate or impact a patient's substance use disorder. The dimension helps identify the need for additional medical services or coordination with other healthcare providers to manage these conditions effectively during treatment. Subdimensions will be physical health issues, impact on functioning and care needs, prognosis, and medical needs. Drivers, influence of comorbid conditions on recovery and treatment planning. Influencing factors, presence of chronic illnesses, diabetes, liver disease. Physical injuries or disabilities, need for medication management or medical interventions, sleep problems. Common standardized measures for assessing the dimension include basic physical health assessments and review of the patient's medical history, with a focus on chronic conditions such as the diabetes, cardiovascular issues, or infectious diseases. Evaluations like blood pressure checks, lab tests, and screening for physical complications are essential for understanding how these biomedical factors might influence treatment outcomes. Payers will focus on, are there co-occurring medical conditions that complicate the patient's recovery process or ongoing medical attention? Approval criteria, the payers are more likely to approve additional treatment days if the patient's physical health conditions, such as those chronic illnesses or acute medical issues, require continued medical supervision or delay their ability to be safely discharged or step down to a lower level of care. Dimension 3, psychiatric and cognitive conditions. Dimension 3 will focus on mental health conditions, cognitive impairments, and emotional disorders that may influence an individual's ability to engage in treatment for substance use disorder. It examines co-occurring mental health diagnosis, past trauma, or emotional challenges that could complicate their recovery process. Subdimensions would be co-occurring mental health disorders, emotional stability and behavioral challenges, cognitive impairments affecting treatment. Drivers, influence of psychiatric history, behavior patterns, and cognitive abilities. Influencing factors, diagnosed mental health disorders, such as anxiety, depression, cognitive limitations, including memory, judgment, or learning issues. Trauma history, behavioral patterns, and stress response. Common standardized assessments used in this dimension would be tools such as PHQ-9, GAD, Columbia Suicide Severity Rating Scale. From a payer's perspective, the key considerations in whether health challenges are present that would hinder the patient's recovery or require mental health treatment resources for the mental health needs. Approval for continued treatment is often granted when unresolved emotional or behavioral issues significantly impact the patient's ability to participate in treatment. especially if these issues present a risk for safety or relapse, and for the member to step down to a lower level of care. Dimension 4, substance use related risk. Dimension 4 evaluates the risk and concerns directly related to the individual's ongoing substance use. It focuses on the potential dangers associated with continued use or withdrawal, examining how substance use impacts the individual's physical health, mental health, and overall social functioning. Clinicians assess the likelihood of harm, such as overdose, medical complications, or behavioral consequences, and determine the most appropriate interventions to reduce those risks. The key purpose of Dimension 4 is to assess the immediate dangers that continued substance use may pose to the individual. This involves identifying the most suitable level of care to manage these risks, whether through harm reduction strategies or more intensive interventions designed to prevent further harm. This dimension is crucial in cases where the individual's substance use puts them in an immediate risk, guiding the dimensions on treatment placement. In summary, Dimension 4 helps clinicians determine how much risk the individual's current substance use behavior places them in, and what level of care is necessary to reduce those risks effectively. Subdimensions would be history of substance use and related risks, patterns of use and potential for harm, health risk, legal issues, and risky behaviors, drivers, environmental, psychological, and social factors that influence risk level. Influencing factors, history of overdose or high-risk substance use patterns, presence of legal or financial consequences due to substance use, impact on family, work, legal, and social consequences. Common standardized measures for this dimension include brief addiction monitor, BAM, and tools such as risk index for overdose or serious opioid-induced respiratory depression. These measures help gauge the severity of risk related to substance use, especially in cases of potential overdose or severe medical consequences. Payers are particularly concerned with ongoing risk tied to the patient's substance use, such as the potential for harm, overdose, or legal consequences if the patient is discharged prematurely. They will also consider whether the patient's substance use poses a direct threat to their safety or to others. Approval criteria for this dimension: payers are more likely to approve continued treatment if the patient is exhibiting high-risk substance use behaviors, frequent relapses, or risky drug use patterns, or if the patient has experienced a recent overdose, indicating a strong need for further care and supervision. Additional considerations for this dimension often plays a critical role when deciding between outpatient or residential, or even if inpatient care is required. Factors like the patient's access to drugs in their environment, history of relapse, and the ability to avoid triggers can all influence the determination of the most appropriate and least restrictive level of care. Clinicians also consider any co-occurring mental health issues or social stressors that increase the individual's risk, tailoring treatment plans to address these specific challenges. Dimension 5, recovery environment interactions. Dimension 5 assesses the individual's living environment and social support system to determine how these factors influence their recovery process. It examines whether the person's physical surroundings, relationships, and community provide a supportive framework for maintaining sobriety. Or if they could create obstacles that may hinder their progress. The primary purpose of Dimension 5 is to evaluate external influences, such as the stability of the living situation and presence or absence of supportive relationships. To understand these elements, either facilitate or undermine recovery efforts. By identifying these environmental factors, clinicians can design a treatment plan that not only addresses the individual's internal clinical needs, but also considers the challenges posed by their surroundings. If a patient's environment is deemed unsafe or unsupportive, a higher level of care, such as residential treatment, may be necessary until a more stable living situation can be secured. This dimension is crucial in determining the appropriate level of care for sustained recovery, especially when the individual faces significant environmental barriers, such as exposures to substance use or a lack of that support system. Clinicians focus on ensuring that they facilitate a discharge plan that includes an environment supportive to long-term recovery. So the subdimensions, quality and availability of social support systems, stability and safety of living conditions, employment, financial and community resources, drivers, impact of recovery environment on treatment engagement and outcomes, influencing factors, presence of the supportive relationships versus enabling behaviors, safety and stability of home environment, access to transportation and employment, access to community-based recovery resources such as AA, sober living homes, NA. Common standardized assessments used for Dimension 5 include tools like brief assessment of recovery capital, BAM, and other treatment effectiveness assessments, which will help gauge the patient's recovery supports and environmental challenges. Payers are particularly interested in whether the patient's living environment supports recovery or poses significant challenges. A patient's social network, home stability, and exposure to substance use are key factors payers consider when approving additional treatment. Payers are more likely to extend treatment if the patient lacks a stable or safe living environment, or is surrounded by negative influences, such as peers still using substances, or has an unsupportive social network. Ensuring that a discharge plan leads to stable, supportive environment is critical in these cases. The patient's recovery environment includes not only their home, but also their community, work, or school settings. External stressors such as unemployment, financial instability, or living in a high-risk area may also play a role in shaping the treatment plan. Clinicians may recommend extending the level of care if they believe patients' home environment or social network could jeopardize their ability to stay sober. And as a result, intensive outpatient or residential treatment might be necessary to reduce the risk until a safer discharge plan can be implemented. Dimension 6, person-centered considerations. Dimension 6 emphasizes the importance of tailoring to the individual's unique characteristics, preferences, and circumstances. This dimension takes a look into account the person's identity, values, culture, and personal goals to ensure that the treatment plan is aligned with what matters most to the individual. The aim is to create a truly person-centered approach where care is respectful, culturally sensitive, and designed to foster active engagement and recovery process. The goal of Dimension 6 is to develop a treatment plan that not only addresses the clinical needs, but also integrates the individual's personal circumstances and preferences. When treatment aligns with the individual's identity and values, there is a higher likelihood of increased engagement and adherence to the plan, leading to more sustainable recovery outcomes. This dimension ensures that the care provided is not only effective, but also respectful and supportive. This person-centered focus is particularly important for patients from diverse cultural backgrounds, those with specific challenges, or those who may have experienced barriers to treatment in the past. By addressing these individual factors, the treatment plan becomes more adaptable and personalized, promoting long-term success and recovery. Subdimensions would be cultural, spiritual, and personal values and beliefs, individual preferences for treatment approaches, barriers related to identity, language, or access to services. Drivers, importance of tailoring treatment plans based on individual needs and values. Influencing factors, cultural or religious beliefs that impact treatment preferences. Language barriers, literacy, or limited access to care. Individuals' goals, preferences for medication-assisted treatment, or alternative therapies. A payer's focus is primarily concerned with whether the treatment plan addresses the patient's individual and cultural needs. They look for evidence that the treatment center is providing care tailored to the patient's personal characteristics and preferences, rather than using a generic approach. Payers may approve additional treatment days if it's determined that the patient requires continued culturally sensitive or individualized care, especially when this care has not yet been fully implemented or completed in the current phase of treatment. Additional considerations for Dimension 6 is vital when dealing with patients who have experienced trauma or who have unique life circumstances such as gender identity, sexual orientation, socioeconomic challenges, or cultural differences. Treatment must be flexible and accommodating to these factors, ensuring the patient feels understood and supported. Taking the patient's readiness for change, personal goals and emotional needs into account can significantly enhance the effectiveness of care provided. This dimension also plays a role in motivating the individual by incorporating motivational interviewing techniques and shared decision making. When patients feel that their personal needs are being heard and respected, they are more likely to stay engaged in their treatment and work toward their recovery goals. So, with breaking down each dimension and going over the subdimension, the drivers, and influencing factors, Rhonda is going to take time during her presentation to incorporate each and every one of these into developing the treatment plan and the interdisciplinary collaboration. At the end, I will then summarize and wrap everything up. So I will now pass the mic over to Rhonda.
Okay, before I go into my specific slides, Megan, I'm just going to let's address a few of the questions that have been coming in, and then we'll actually take our short 5-minute break, and then we will continue on. So one of the questions that came in that I'll turn over to you, Megan, is a particular person works in a substance use residential setting. And when updating the ASAM, is there any one particular dimension the insurance companies pay more attention to than the others?
That is a great question. Each dimension is assessed independently, but there are factors that could drive a decision for qualifying for more time, such as the member not having a stable support system, access to care, or the needs have not yet been met. This is why it's so important to have that individualized treatment plan that is updated on a regular basis so that we can paint that picture to the payers of what still needs to take place in the current level of care and what progress we have made and what we're going to work on. So medical necessity is extremely important and considered in each and every dimension. The majority of denials come because of medical necessity. The payers feel that someone can be supported at a lower level of care. So the question that payers will take into place is what needs to happen at the current level of care that cannot take place at a lower level of care. So just keeping that in mind and reviewing what the member will be discharging to will help determine if the member qualifies for additional time.
Yeah, thank you for that. And I'll definitely dive a lot deeper into that in my section of the presentation that's really going to tie into like, okay, how do we do this, right? And I'll get into the specifics of like how we're documenting not only in our treatment plans, but in our notes, our family notes, and the aftercare plan that also helps drive whether or not the insurance company is going to approve a patient to stay for medical necessity. We're going to do 2 more quick questions and then we'll go to break. How are treatment outcomes monitored? So I'm actually going to be covering some of that in my piece of the presentation. So we'll kind of hold off for that. And if there's anything else in addition that you would like to know specifically, you can just feel free to kind of double back at the end of the presentation. I'd be happy to cover that, but that is definitely a part of my presentation because it's critical and how we're monitoring progress, which is something also that's very important that ties into medical necessity and the level of care that will be approved. The last question I'll take for now is there's a program that uses an app that gives a member options for goals and steps on a treatment plan with no way of choosing their own goals and steps. So a huge part of my presentation is going to be creating person-centered treatment planning where actually the patient is involved in creating their treatment plan. And we'll talk about the various reasons as to why. I will say this, if you're coming from a program, which I am familiar with some that have an EMR system, even where you can just kind of, the therapist kind of click, you know, goals, objectives, and interventions. And that doesn't allow for it to be in the patient's own words, right? I think that's kind of where your question's coming from. So I will show some examples later on in the presentation of if it does do that, how I at least teach my teams that I work closely with how to still create it in the patient's words and to show that they were actually a part of it. But it does make it extremely difficult. And the majority of our regulations do speak to the patient should be involved. It's their plan. Megan mentioned it many times throughout the presentation, how important it is. Just I always, when I train and interact with therapists, I always look at it from a perspective. If I was a patient and I'm in care and somebody kind of just handed me something and said, hey, this is what you're going to work on. And like I wasn't there kind of part of, you know, that development and I didn't see it as really mine. It often can be less likely, to Megan's point, that they're actually going to be engaged. So we'll talk about a couple different ways of how to do that. And like I said, if we can be of any help after the presentation, you'll have our contact information. I'd be happy to follow up on other ways to do that that we may not cover. So I'm going to turn it over to Callie for us, I believe, if you want to give us the time for the break. She might not be on. So what I'm going to say is let's come back. It's hitting 11 o'clock. So let's come back in about 5 minutes. We'll start back up at 11:05 Eastern time. All right. We'll see you in a few minutes, everyone. All right, everybody. So welcome back to the break. I'm going to jump right in just because I have a lot of information to cover. And we also have a lot of great questions coming in. So I definitely want to allow some time for that. And Megan and I can also stay on a little bit after the presentation for any of those that we may or may not get to during our time here together. Okay, so Megan spent the first part of the morning really talking about each of the dimensions, focusing more on what the payer side is looking for. So over about the next 45, 50 minutes, I really want to take a deep dive into, okay, we know this information, but how do we do it, right? So my experience as a clinician myself and working and supporting and teaching a lot of clinicians out in the field, how to create plans, create individual notes and aftercare plans, it often lies in like, okay, I get it all. I understand the why, but like, how do I take this knowledge and how do I actually get it into the document? How do I include the patient? How do I include the family? How do I include the interdisciplinary team? So I'm really going to take a deep dive and let's talk it through together. So let's start with creating person-centered treatment planning. So here are just some of the key components that we want to take into consideration as we're building out the plan, with the main focus that it's in the patient's words and it's a shared process. So I'm not going to go over the ASAM until I get to the other slides, but obviously we're going to take into consideration any assessments that we've done with the patient. I know on this call, we're all coming from different treatment settings. So whatever those assessments are that you use in practice, we have them for a reason. So I'm often explaining to people, like, it's not like clinicians are always like, hey, you guys are always giving us more work. No, it's actually about every single thing that we're asking a patient is actually helping us to provide information and be informed about what that patient's actual needs are that should be incorporated into the plan of care. So we're going to use the patient interview, right? We're going to pay attention to patient history. That's critical. And I'm going to talk about that a little bit further along in the presentation. And then I always say that to therapists, use their clinical judgment, right? Because people will say, okay, well, like some of it's a self-report. Absolutely. We know patients are going to come in, especially, patients at different level of cares, whether they're coming in detox and, maybe they're still intoxicated and their judgment's off. And, we have to take those things into consideration as we're assessing the patient. And that's why the treatment plan is a living document, right? So as we gain information, as we gain clarity, we make updates to it as we go along. So it's really important, like, how's the family involved? Do you have a family call? Do you have family sessions? Is there any kind of family assessment that you use as part of your interview process that helps you build out the individual plan? Biopsychosocial is critical. There is a wealth of information. I know most of us that are using BPSs, we often think they're quite long, but there's such a good purpose and intent to the BPS because it's assessing the need of the patient that then we're going to kind of pull out from each of the disciplines within our team and see how we're going to incorporate that into their plan of care and how we're going to monitor that throughout the entire treatment process. Nursing and medical assessments, critical, because we know the treatment plan is not only going to address specific substance use or mental health disorders, it's also going to be imperative that their medical diagnoses and symptoms are also included in the plan of care. Oftentimes, I see urinary drug screens. Like when I'm working with, facilities and I'm helping therapists, it's something they might not initially think of taking a look at. But in substance use disorder care, the urinary drug screen should be influencing treatment. And what I mean by that is patient might come in, you have a patient interview, and the patient says, yeah, I'm here for, cocaine use, and I'm really struggling with my anxiety. If you're not taking a look at those UDS results, there could actually be other substances that patient's positive for. And if we're not looking, then we're not incorporating into the treatment plan. So I'm kind of keep on going back and forth around the why behind these things are so critical when we're building out person-centered treatment planning. Outcome assessments is a huge one. I am 100% going to touch on that throughout the presentation. but I definitely encourage you to sign up for next month's webinar where Trish Caldwell is going to take a much deeper dive into outcome assessments and how we incorporate that directly into the treatment plan, and we incorporate skills to help a patient build their recovery capital. But I will 100% be talking about outcome assessments because they're critical, and it's one of the questions we got, and it's extremely imperative that you have a way to measure progress within your treatment plan. So I'll give a couple of examples of how we'll do that as I start to take a deeper dive into some of the dimensions. So for each dimension, I'm going to focus on the treatment considerations. And what I mean by that is, again, like when you're the one kind of sitting at your computer and you're like, okay, I have this wealth of information. How do I take this information as the clinician, right? Or maybe you're on the call here today and you're a clinical director, you oversee a facility. How do I incorporate this into my plan, my notes, and aftercare, as well as your treatment team? Like, what is your process to include the interdisciplinary team in care? So I'm going to talk a little bit about that towards the end of the presentation. I will provide a resource that we created that will break down each of the dimensions that we spoke about today, and it will include these treatment considerations. So you can also share that not only with yourself, but if you work with a team, that can also help them when they go to write their ASAM or they're going to write their individualized treatment plan. They can use it as a reference to say, okay, well, what really should be included in that dimension? And what's the relevancy of it? So you'll have that entire tool to use with your team. So let's break down dimension one, acute intoxication, withdrawal potential, and addiction medicines. So Megan mentioned on it a little bit, but it's really important that we know the current and past substance use. Not only that, but we want to ask the patient, like, what is the preferred substance? Because again, all these things, as I'm thinking of them, it's okay, how am I then going to incorporate and prioritize their plan? So I'm always kind of keeping that in the back of my head as I'm going through the dimensions and the treatment considerations. How do I decide kind of like, how am I going to tackle this and not have a plan that's like 16 pages? So we'll talk about how to kind of prioritize that. So I want to know the preferred substance. It's important to know their history of withdrawal. It's really important to know what risk level is associated with their intoxication and withdrawal. And that kind of covers a few bullets down when we talk about their CALs and CWAS, where that's really assessing like their symptoms of their opioid withdrawal or their alcohol withdrawal. And the reason why it's important for the treatment plan is because we want to be knowing how those symptoms are potentially affecting the patient. So we then can provide that information to the entire interdisciplinary team. And I'll talk a little bit more about that. We want to know, is the patient coming in and letting us know, like, hey, we experienced some pretty severe withdrawal or seizures based on previous history. That's going to allow our team to be better equipped and be proactive and have a better expectation of what may be happening with that patient in care, and what can we do as a team to make that patient as medically as comfortable as possible. Their use of substances, the amount, the frequency, is this a new substance? Is this a chronic issue? These are all things that also tie into the question that was asked about medical necessity. The more detail that we're providing in all of these bullets that I'm explaining is also going to significantly help when you look at the payer side, because it's going to show the elevated risk. So when we show elevated risk along with the necessity of them being at this level of care and why, that is then going to be helpful in patients being improved to stay in our care. So current signs and symptoms of withdrawal, associated risks, cravings, and urges. So something I'm going to mention where that might come into like kind of the therapist monitoring is using whatever assessment you use. You may not use the BAM. I reference it in this presentation, but there's probably some type of symptom rating scale, evidence-based measure that you and your teams use to measure the progress of substance disorder progress in treatment. So we use the BAM. The BAM has specific questions that pertain to cravings and urges, as well as our medical and nursing teams are asking that daily, right? And we're also assessing that through the CALs and CWAS. So the importance of this for the therapist may not be understanding necessarily all the medical lingo, but it's how we incorporate the interdisciplinary team and their knowledge and what we need to prioritize and target at the beginning of treatment. So we're going to be checking. It kind of goes back to the question that was asked about like how do you assess outcomes, right? One of the best ways that I can answer that is through symptom rating scales. So the BAMS one, vital signs, the CALS and CWAS. So it allows us as our teams put in place objectives and interventions, we'll see the impact that it has on our patients. You know, are things improving? Are they not improving? And then what is the team doing to assess those? So that's going to bring us to dimension 2. So biomedical conditions. We're going to be focusing on what is the patient's medical needs? What is their health history? Okay. And again, we may not be dealing with all of this at our particular level of care, but if we're not, it's still a patient need. It's still a risk level. It could be a barrier for their treatment. So within that team approach, we're going to see, okay, what are we going to deal with in our level of care? And what are we going to incorporate into the aftercare plan? Is there any current or physical health needs that we need to be aware of, right? Is there chronic physical health conditions that could affect treatment? That allows us as a team to be proactive in the care that we're providing to the patients. In dimension 2, you definitely want to be documenting about any sleep issues. And remember, things do not have to be a diagnosis for them to be addressed. So a patient doesn't have to have insomnia necessarily for it to be in dimension 2. But we want to be really specific. So as specific as we can be, you know, is the patient saying, hey, I'm only sleeping 3 hours a night or whatever that is, like I can't fall asleep, I have difficulty staying asleep, as much detail that you are able to write within your documentation and in your treatment plan, the better. When's the patient's last physical and dental appointment? What follow-ups needed? Reason why we're asking that is, again, if you look at some of our outcome measures, the BAM asks about physical health. So again, it's really important to know, has this patient seen a PCP? Is the patient reporting in the initial assessments that they have dental issues? Sure, we're probably not dealing with their dental issues at this level of care, but it's still risk. So I always look at these things of what is risk and what are we doing internally, and then what are we going to do externally in their aftercare plan to support them? Because we know when pain is unresolved, that can lead to exacerbating other issues, right? So it's really important when we take that holistic approach that we're paying attention to all of that. We may not be currently dealing with it, but how are we documenting in that? And that all really does go into medical necessity. Something else that's really, really important that I see from both a treatment and where Megan was talking about the payer side for documentation is medication compliance. When they look and evaluate a patient's chart, if they notice like a patient is not getting better, right, based off of how we're writing, their symptoms, their behaviors, their risk level, there's often a question around why was the medication not adjusted? So it's extremely important that our providers within our treatment teams are documenting the reason as to why or why not. And then the therapist can also kind of incorporate that into their sessions as they're talking with families, as they're talking with patients, so can really continue that holistic approach. But what are their medical needs? I always tell therapists, we have to look back and pay attention to medical notes and provider notes. Because if we don't, we could be missing that a diagnosis was updated, or maybe there's an additional diagnosis. And how would we incorporate that into our treatment plan? One, if we don't have a process within our larger system to have that communication. But for sure, if you're not going back and reviewing some of those notes, some of those things can be missed. So we want to take that into consideration when we're doing treatment plan writing. Have you collaborated with outside providers? Extremely critical, right? Again, I always put myself back in the space of a patient. If I'm a patient and I don't want to constantly feel like I'm starting over, I want my teams to be working collaboratively together to give me the best experience and not having to kind of keep on like explaining myself. And this is what I did here and this is what I did there. But when we focus on obtaining ROIs, we can work and get some of that history and collateral information that's going to be significant in working together for that particular patient. In Dimension 2, if it's applicable, if there's any pregnancy-related concerns, you want to go ahead and tuck that in right here with any specifics of follow-up that are needed. So then you have Dimension 3, psychiatric and cognitive conditions. So we're looking at any psychiatric concerns. Megan mentioned it a little bit, any co-occurring disorders related that could be complicating the substance use. One of the outcome assessments that we use is the PCL-5. So regardless, every single patient coming in, we're doing the PCL-5, we're doing the GAD-7 and the PHQ-9. We're assessing that at specific intervals depending upon the level of care the patient is in, and at discharge for every single patient, whether they're in inpatient care or whether they're in outpatient care. That is helping us to assess whether or not the patient is making progress in the areas that we're targeting on the treatment plan. You can choose to use whatever those assessments are. If you have any questions after the presentation, I'm happy to give. I have a bunch of resources I developed to help teams understand how to understand the context of the score, as well as the interpretation and how you would then write that in a plan. We want to look at treatment barriers. Really important. Barriers, I always equate that to risk. So our job as professionals is to support patients in decreasing risk and increasing protection, which is the recovery capital, right? So again, in Dimension 3, you do want to focus and document within your notes and treatment plan whether or not the patient is taking their prescribed medications and whether or not the patient is saying that they work. So what's the efficacy of the medication? Because if they're reporting that it's not, we can be collaborating with the provider. Something else that I think is really important in treatment planning when it comes to medication, if a patient isn't compliant with their medication, this is a great opportunity. That is a clinical issue and should be updated within the treatment plan. And it's more so, what are we doing as the treatment providers to support that patient in taking their medication, which hopefully will then help kind of decrease some of that symptomology. Has the treatment team collaborated with outside providers in aftercare? And something really important when it comes to safety is this patient at an elevated risk for SI or SA? If so, in any of the assessment process throughout, whether it's admission, throughout treatment and discharge, it's extremely important that that treatment plan, it's incorporated in the treatment plan, what are we doing, and that the patient has a safety plan. So we're going to jump to Dimension 4, substance use related risk. What are the patterns of use? What's the history? How can we utilize that knowledge as we're building out their treatment plan so it's specific to the patient and they're involved? Megan spoke about it a lot, about just the risky behavior, the injury, the overdose. Is there impaired driving? Is there criminal behavior? How are we taking those things into consideration as we're prioritizing the treatment plan as well as the aftercare plan? So we want to know, is the patient aware of their triggers within their daily environment? And next month, Trisha's going to talk a lot about like, what are specific skills that patients can be directly utilizing with those triggers. So, and how to incorporate that specifically into the plan. So I won't go too deep into that, but it's important to know, like, what is the patient's access to substances? What is the effect it has on their relationships? Has it affected their employment, education goals? And the reason why I'm saying these things is if it has, these should be incorporated into your treatment plan because it's a part of patient barriers and it's a part of patient risk. So that's specifically why we're asking these particular things in each of these dimensions. And what's the likelihood of the risky SUD related behaviors, right? So we want to also know, because depending upon the risk of maybe like the patient's home environment or their work environment, that may help us influence as therapists what the clinical recommendation may be for discharge. Which brings us to Dimension 5, recovery environment interactions. What's their ability to function in their current environment? Is it safe? Is it supportive of their recovery? We all know in working with our patients, this may or may not be the case, but the information is important for us to then incorporate what do we then specifically do as the interdisciplinary team to help support this patient to be in the most supportive environment? If we know they don't have support within the home, it's going to be really, really important. Can we get them connected with a sponsor? Can we get them connected with alumni? Can we identify some supportive network of connectivity for this patient? So that would be on the treatment plan, because that is a barrier. So the reason why I'm mentioning these things specifically is because it all ties into the individualized treatment planning for the person. Because if you incorporate these specific things, like if we know their home environment isn't safe, then that may be something specifically, instead of just saying, oh, we're going to develop an aftercare plan. Let's be specific and intentional about what those objectives are and what the interventions are to help that patient maybe get to a safer environment. So we want to know early on, like, do they need housing? Is there financial barriers? Is there vocational barriers? Is there legal barriers? All of that would be incorporated into a person-centered treatment plan because it's specific to that particular patient and their risk level. Childcare services. Why I emphasize that is if I'm working with a patient, say we're an inpatient and we're going to transition to an outpatient level of care, that may have to be considered depending upon whether the recommendation would be PHP or maybe IOP. Because if they don't have childcare, it wouldn't be appropriate for me to put them maybe in a PHP program because they're just saying, I'm not able to do it. So again, we have to take these things into consideration, which automatically makes it person-centered because it's specifically about the patient. We want to examine whether or not a person's family, friends, coworkers may pose a threat to their treatment and recovery. And then we can kind of incorporate how are we going to address that. Then we're going to go to dimension 6, person-centered considerations. Megan talked a little bit about it. We're going to focus on motivational enhancement. So we're going to kind of address some of that ambivalence to treatment. That may be with the patient, that may be something that we're supporting also with the family. So I don't know what your program offers, but our program, we have specific like family webinars and education and training that is also teaching patients alongside. So they also can help us in some of these areas to kind of motivate, build an understanding to deal with some of that ambivalence. Patient preferences, extremely important. They're often asked on the BPS, as well as barriers. Whatever those preferences are as a therapist, think to yourself, as you're building out that treatment plan, how can I incorporate what the patient told me they preferred actually into the plan, right? That's how you create that shared decision-making and involvement. So I'll go ahead and give an example of that. Maybe I meet with a patient and they say, you know what, I really prefer to go to the gym. I really like to exercise. So then as I'm looking at like that BPS and I'm seeing this patient is, reporting like high anxiety, high stress, and I might incorporate into the plan, even if they're in inpatient, okay, well, why don't we start out each of your days with maybe like 10 minutes of exercise, right? Or how could we incorporate into the end of their day, whatever it works for them, but it's me incorporating their preferences of things that they say that they enjoy into their actual plan, which essentially will like make them feel part of as well. What is the goal for the patient and therapist? To practice shared decision-making to determine level of care. So again, this is the patient's treatment. This is the patient's treatment plan. How are we involving them? How are we prioritizing based off of what their specific needs are and what they also would like to see happen in their specific treatment? So 2 little quotes that kind of stood out for me that I just wanted to just pause for a second and just talk about. Success is the sum of small efforts repeated day in and day out. It resonated with me because as I'm working with patients and therapists, sometimes we need to remind ourselves and even ourselves, right? Give ourselves a little grace. When we talk about change and we talk about skill building and treatment planning, it takes discipline, it takes practice, and it takes time. So we just need to be patient. We need to do those small efforts day in and day out, and we'll reap the success of that. The only person you're destined to become is the person you decide to be. We're reminding people, right? They're not defined by their past or past choices or by a diagnosis. they have the capability to be whoever they want to be. And we're going to hear that. We're going to learn that from the patient, right? We're going to take time to know what are your goals? That's personalized centered treatment. How are we going to help you achieve the person you decide to be? And really focus on that positiveness and that optimism and just remind them they're capable of anything. So I'm going to jump in now to just a little bit more detail in the treatment planning. I'll reference in the next couple slides. I created a resource that we'll also send to you that feel free to use for yourself or use with your teams. So as I as I go to some of those slides, I'll let you know what those specific resources will be that you'll get at the end of the presentation. So I'm just going to run through some of this briefly because we have touched on it a little bit. Involve the patient and what their goals are. I get a lot of questions from therapists to say, okay, like the BPS takes a lot of time. Like, okay, how do I actually incorporate them without that having to be something separate? So I say, as you're assessing a patient through whatever the assessment tools it is that you use, you might just say to them, if they're identifying, yeah, I'm really struggling with anxiety, I'm really struggling with depression, I'm really struggling with my substance use, it's ruining my relationships, right? So I might say something just simple, okay, what is it that you would like to work on with your anxiety? What would you like to see different? And then in that conversation, the patient may give me something back, something like, I just want to feel less anxiety throughout the day. Or maybe I just want to go into a room full of people and not feel, that knot in my throat. Whatever it is, that's the personalized part. That's what I'm going to put in quotations. That's the goal. That's the measurable piece that I'm going to start to work on attaining with the client. And I'm going to show you some specific examples of how to do that. All the assessments, no two journeys are the same. And I say that to say, no two treatment plans should look the same. When we are considering and all the things that Megan and I mentioned so far, no two treatment plans should be the same. If we are utilizing the ASAM and we're utilizing our assessments and we're utilizing the context of the assessments, we will have a wealth of specific information that will help us drive care for our patients. What's worked in the past? If we have a patient we worked with before, or maybe an outpatient, or they're back in our facility, let's take the opportunity to use the information we have. Maybe let's consider what has not worked, right? I don't want to have a patient leave at the same aftercare plan that we know that didn't work, right? Or that wasn't effective. So we do want to take into consideration those things. Collateral information. Excuse me. Is it from, maybe a support person that we could get our ROI from? Do we have any information from the family, whoever they see their family as, right? As much information as we can have, it helps us build out the most realistic, comprehensive, measurable treatment plan that we can. Strengths and preferences, critical, and barriers and risks. So we talked about that. So let's jump right in. This is the resource that I'm going to provide you at the end of the presentation. What I did was just create a little box that has what specifically goes in a goal, objective, and intervention. And it's been really helpful for some of our therapists to just kind of have that as a desk reference guide. So as they're sitting at, or as we are sitting at our computers and we're writing treatment plans, it helps us keep focused. If we're following the SMART format, these few little bullets are going to keep you very targeted and as you're writing. So let's think of a goal, right? If it's the patient's treatment plan, what is the goal that the patient identifies that they want to work on? Include patient's words as often as you possibly can. Go ahead and put those quotations right on your treatment plan. Include the patient's strengths in the goals, right? We want to make this strength-based. Let's help them. Sometimes it's hard for our patients to say what they're good at. They're often not feeling too good about themselves. However, use the assessment process and pull strengths out of that. Help them to identify the strengths they have. I worked with a guy once. He's like, I don't have any strengths at all. The gentleman had like 35 years at his job. I said, wow, you're a loyal person. I mean, there's a lot of strength in that, right? So if they're unable to provide their strengths on their own, which we should be asking, there's other ways that we can help them, and we want to incorporate them into the goal. Is it attainable? This is always a big one that I say. Is the goal attainable in the time that the patient is in our care? right? Whether it's outpatient, whether it's inpatient, we often have an estimated time and we know we have treatment plan updates. So let's make sure that we're putting things that are actually attainable and achievable, that we can track that progress. And are they measurable? And I'm going to jump into examples of exactly what that looks like. So next, we could use this as a resource for the objective. The objective is still the patient, right? So the goal's what the patient's going to do, the objective's what the patient's going to do. So what is the patient specifically going to do to achieve the goal that they just told us that they're looking to achieve? We want to word it in a way the patient understands. We shouldn't look at a treatment plan that's all this like clinical lingo that if it's the patient's plan, they don't even know how to articulate what it means, or if we're working with a family that they wouldn't be able to understand what the patient is doing and what the team is doing to help them achieve the goal. Always have the when and how, right? Because again, how is it measurable? How do we measure progress if we don't know specifically how the patient is going to do, when the patient's going to do it, and what specifically they're going to do to achieve the goal? So that's really going to help us measure outcomes, which kind of goes back to our question earlier in the presentation. Add in a specific skill. Trish will have an entire presentation about how to do this, but we train all of our therapists to be specific to what the patient is going to practice or do specifically. And that also helps us to monitor what's working for the patient, what's not working for the patient. Is it measurable? And are we utilizing outcome assessments? The intervention. The intervention now turns to others, right? So the intervention now is, how is the outpatient therapist? How is the psych NP? How is the medical provider? How is your behavioral health tech staff? How is your nursing staff, if you're in residential, being supportive to help the patient achieve their goal? So we are going to identify in each of our interventions who we're going to name the person by position, right? What will the staff specifically do and when? And the reason why I keep on emphasizing the specifics and created this little, I call it a desktop resource for the teams, is because if I don't write in this way, how do I then go back and document progress, which all then ties back into what the payer is looking at from Megan's point. How are we documenting the problem, but how are we documenting what are we going to do to support the patient with the problem? And then how are we documenting progress? So they're the three key areas I always train therapists on thinking about as you're writing notes, especially. So I wanted to show you just a few examples of like what that looks like, right? I won't go through all of them. You'll have the slides. If you need any more examples, we've built out a wealth of examples for our team. So a goal. I don't want to feel anxious all the time. Okay. Patient's words, patient-centered, pretty easy to understand. And we know we can measure it, right? We can measure anxiety in very different ways, right? So Chris is going to use his openness to learn skills to reduce the frequency and duration of anxiety symptoms, right? So it's very specific. What is he going to do? What are we targeting? The reduction of anxiety symptoms, right? So now in my objective, what I've taught therapists is utilize outcome assessments because that'll help me be able to gauge patients' symptoms. So symptom rating scales are one of the best ways to measure progress in treatment because as I'm providing the patient with the assessment, even if we say, hey, it's a self-report and the patient is like 0, 0, 0, 0, then I'm using my clinical judgment. My team's using their clinical judgment. So regardless if the assessment we feel is accurate or not, we're still using our clinical judgment to target progress or not. So my goal is, Chris wants to, decrease his anxiety. He had a score of 15. We're going to decrease it by 5 points. And we're going to practice a specific skill 3 times a day, as well as Chris taking his medication. Okay. So the intervention is going to be, we know our therapists are teaching it in group, right? So every single day we're teaching in group a skill to the patient, but we're also going to follow up an individual session to ensure that Chris is actually understands and is utilizing the skill appropriately. So we're going to do a little practice. So if you look, all of those match up to what we said on the previous slides. Who's going to do what, how they're going to do it. I'm going to know whether or not it's working. Chris is going to know whether this particular intervention is working, among others, in his medication, because when we reassess his symptoms and his self-report, we're hoping that there's a decrease in that. So there's a few more examples. I won't go through them all, but I wanted to put them on the PowerPoint so you have them as a resource. One thing I will point out in this is everything doesn't have to be separate on a treatment plan, right? So, everything doesn't have to be like a separate goal and a separate problem necessary. It's that it's inclusive and it's addressed if it's a patient, risk or problem. So this patient comes in, I don't want to drink anymore. It's ruining my relationships. So this problem may have been tucked right under his substance use. But the example I wanted to show you here specifically is I'm also listening to what Chris is saying. He's saying it's impacting his relationships. So within that section of the treatment plan, I can go ahead and tuck in the connection with the family, the connection with the supportive network, whoever that is. And then I'm going to tuck in specifically, how is that going to happen? And what are we going to do? So that's more of an example of just that, like everything doesn't have to be separate. You want to put things in a treatment plan where it's relevant to the patient based off of the information that they've given us. Here is just another example I'll leave for you guys on how to incorporate the BAM risk assessment into measuring progress in substance use care. Something else that the payers definitely like to see is evidence-based measures, scores. What are we doing to help decrease the risk? Especially if the scores are coming in high in whatever assessments you use, you want to make sure that you're putting specifics to that, not only in the ASAM, but identify those specific risks and high risks on the treatment plan itself. So here's just an example of how to incorporate medical into the treatment plan. So you'll have that. And then I want to jump into talking a little bit about the interdisciplinary collaborative approach in treatment and why we do it and how important it is. It's extremely important as we're building out those treatment plans, depending upon the setting you're in, that you're bringing the team together for a holistic approach to patient care internally and externally. So we talked about that with the providers. This is going to improve patient outcomes. Trish is going to talk a lot about that next month, but I want you to think about what I mean by that. If you have specific rating scales and outcome assessments that you're utilizing in treatment, we have the ability to target areas of patient need early and often. And then we have a very good assessment process as we continue to use those outcome measures throughout treatment and a discharge to be able to say, are the patients coming to us getting better or not? We know that's not the only source, but it's a source and it is an important source to incorporate. So we want to see, is it improving outcomes? Are the patients getting better? How is our treatment affecting readmission rates, right? Are patients, sticking with aftercare, right? Are we creating comprehensive aftercare that patients are actually showing up at their appointments, right? Are we involving their supportive network to also know what those plans are? It's going to reduce costs. It's going to reduce costs for the patient as well, right? Because if we're targeting specific treatment, we're hoping that we have outcomes that are more targeted as well. And patient satisfaction, the most important, right? Quality of care and patient satisfaction. What patient wants to come into treatment and not feel as though that their needs are being heard, but not only heard, are they noticing that it's actually incorporated into care and that the entire team is doing something about what they're so desperately seeking help for, right? That they're not retelling their story over and over again, that your program, wherever you work, has very good, strong processes and systems in place of sharing of critical information and integration. So our patients are satisfied, they're feeling better about themselves, and they're improving their quality of life. How does the team discuss outcome assessments? Measurement-based care is impossible. There is no such thing as measurement-based care if, one, you're not doing the outcome assessments at a regular cadence, but if they're not being integrated into the entire interdisciplinary team, because measurement-based care is basically saying that you are taking these outcome scores and measures, right? And you're working as a team, whether it's something coming in from medical off the assessment, whether it's something coming in for substance from anxiety, how is it shaping your treatment plan updates and the next care? How is it shaping your objectives being updated? How is it shaping patient goals? And then chart compliance, I won't go into a lot of that, but also the purposes that all of us have some type of documented process in which we're documenting multidisciplinary care. If anybody wants this or feels that this would be helpful, I can add it to the resources. I'm just going to go over two examples. I had created a treatment plan agenda because we all know when we come into a meeting and we start talking about patients and we know that we only have a certain amount of time to do so. And, we have a lot of important people in that meeting, right? Providers, therapists, direct care staff, nurses, and so on and so forth. We have to be efficient. So what I did was in each of the positions that are part of the interdisciplinary team, we want to provide them bullets to say, okay, when it's your turn to speak on a patient, let's not forget these key areas. And if you think that they correlate very similarly to the ASAM, right? So it also helps you build your ASAM note, it helps you build your treatment plan, and it helps you build your specific clinical notes of what you're working on with the patient. So I have just two brief examples for you, but if you would think it would be helpful, I have all positions on the one that we share with our teams. So if it's the nursing staff's turn to present in the treatment team, they can just go through this. Is it relevant or not, right? This is an opportunity to make sure the whole team's on the same board. Was there medication changes? If not, why, right? Hey, is the patient coming to the nurse's station for medication? We need to make sure that the therapist knows that, right? Because if the therapist doesn't know that, how is it then incorporated into the treatment plan as a clinical issue? And how are we all then able to work with the patient to get them to start being medication compliant? And more importantly, to hear their needs as to why they're not, right? So there's an example. Here's an example of what we're asking therapists to report out on, right? Is there a safety plan, any high-risk behaviors? Is there something in your session that you're practicing that maybe you can share with the rest of the team, especially if you're in residential, or maybe is there things you could share with the patient's family, whoever you have an ROI for, right? Another outside provider. How are you sharing, recovery skills plans with the rest of the team? If there's any newer updated diagnoses from a clinical perspective, the therapist could also make the team aware of that. And then any significant adjustments, maybe with the outcome assessments. I may just mention, hey, the patient's anxiety was pretty regulated, but, they just had a really bad phone call and they're just really out of sorts. So those are things that I want to make sure the rest of the team knows, right? Because that way the team responds with a sense of understanding. Right? And that's a trauma-informed approach where we can be proactive when we're sharing the appropriate information within a treatment plan meeting. So there's just two examples. Obviously, like in the main example, I have all of the spaces. So I'm going to go ahead and turn this over to Megan. Just give me one moment. Okay, Megan, you're good to go.
It's not allowing me to share my screen. Do you just want to continue to share?
Sure.
Thanks.
Yeah, no problem. Just go ahead and make me back the host and then I'll pull it right back up. We're just going to wrap up for a few moments and just do a quick summary of what we spoke about today, and then we'll hang on for the other questions in the chat.
Okay, so I'm just going to re-summarize and then have a few final takeaways. So the ASAM criteria serves as a valuable tool for payers to ensure that the treatment provided is both medically necessary and cost effective. Payers rely on thorough clinical assessments across all 6 dimensions to evaluate the patient's progress, risk factors, and readiness for discharge before approving additional treatment days. If you work with a utilization review team, it is very important for the UR teams to be provided with clear, evidence-based documentation. It's critical in demonstrating the need for extended care and ensuring the continued approval of treatment. Some key highlights for the takeaways: person-centered care. The ASAM 4th edition provides a comprehensive framework for person-centered care, allowing clinicians to address not only clinical factors, but also the individual's social and personal circumstances. This holistic approach ensures that treatment is tailored to each person's unique needs. Interdisciplinary collaboration. Successful treatment planning requires interdisciplinary collaboration among clinical teams, medical staff, and UR professionals, as Rhonda mentioned, working together to create that detailed and individualized care plans ensure that the patient's full range of needs are met. Thorough documentation. Clear and comprehensive documentation is essential to justify treatment decisions, track patient progress, and align care with payer standards. Ensuring that documentation ties each of the ASAM dimensions to the treatment rationale strengthens the case for continued care. Best practices for documentation. To effectively use the ASAM criteria in documentation, clinicians should clearly articulate the rationale for treatment decisions, interventions, and patient progress. It's crucial to link each of the 6 dimensions into the decision-making process, making it easy to see why a particular level of care was chosen. Furthermore, documentation should be flexible and updated on a regular basis to reflect any changes in the patient's status or needs as they progress through treatment. Remember, when UR is speaking with the insurance company, it's either by fax, portal, or phone. So it's really important that every detail is clearly documented and also explaining the why. When UR faxes the chart, they're getting exactly how the chart presents. Timestamps, documentation, it's reading as is. And it doesn't necessarily always paint that picture of what the clinicians and medical staff may be seeing on the unit. So it's very important to clearly document all the details. The role of the payers. Payers play a very key role in determining whether a patient's clinical presentation meets the threshold for medical necessity at the requested level of care. When applying the ASAM criteria, payers evaluate the individual across all 6 dimensions to confirm that they meet criteria for admission or additional days for the specific level of care. They are responsible for assessing the quality of services provided by the treatment center to ensure that care is delivered as promised. Some common questions payers may ask include: can the individual be safely and effectively treated in a less intensive level of care? Is the focus of caring preparing the individual to transition to a lower level of care? Is the patient receiving the necessary services to facilitate this transition? Are we getting value for the services we are paying for? In summary, providers aim to ensure that individuals receive the care that is deemed necessary based on clinical assessments, while payers focus on ensuring that the patient is in the appropriate level of care for the necessary amount of time. Medical necessity must align with these basic elements, which includes treatment should be reasonable in terms of amount, frequency, and duration, as Rhonda touched base on. Treatment should be necessary based on the individual's substance use disorder. co-occurring conditions, and overall level of functioning. Treatment goals should be targeted and measurable. The treatment should be effective with improvements expected within a reasonable time frame. Treatment should be delivered by a skilled professional with appropriate qualifications. To gain approval for more treatment days, UR teams must provide this clear documentation that aligns with the ASAM criteria. Clinical notes are detailed, up to date. Progress reports are detailed and up to date, addressing each ASAM dimension. Justification for continued stay, specific reasons why the patient is not ready for discharge, using clinical evidence from the 6 dimensions. It's very important. As a clinician, you can't just say they're not appropriate to discharge. We have to paint that picture as to why. Treatment adjustments, description of changes in the treatment plan based on the patient's ongoing assessment, demonstrating individualized care. Discharge plan readiness, evidence that the patient's home or recovery environment is not yet supportive of or safe for discharge. I will say, working very closely with insurance companies, they expect discharge planning happens day one. So it's very important to start figuring out what needs that patient has or member, as Rhonda stated, and start making reasonable goals that can be met while they're in that specific setting. By following these principles and ensuring strong documentation, both providers and payers can work together to ensure the best possible outcomes for patients. Often, assessments occur when an individual is in times of distress. A person entering care may distrust the healthcare system. They may not think you have their best interest in mind, or may think that if they disclose how rough their life is right now, they may get in trouble with child welfare, their partner, criminal justice, or their employer. How the assessment is conducted can impact how forthright the individual will be, and in return, the success of the assessment and accuracy of the level of care recommendation. It is important to recognize that patients may have different levels of readiness in different dimensions and subdimensions. An individual might be more willing to make some changes over others, which is okay. Don't let this hinder their care. It is part of their process. Action stage readiness is not a prerequisite for any type of care. During the assessment, think of each individual's unique personal experiences and worldview, and create an environment that feels safe, transparent, and inclusive. When an individual is new to your care, acknowledge you do not know them and they do not know you. And express your honest desire to determine what the next best thing is to support their wellness and recovery. A well-conducted assessment can empower the individual to commit to the needed care. A poorly conducted assessment can leave the individual feeling judged and dismissed. Only the clinician conducting the assessment can foster positive interactions that leave the individual feeling heard, respected, and supported. Continued services generally recommended for the individuals who are progressing or are expected to progress, but whose dimensional drivers still need to be resolved to support the transition to a less intensive level of care. Transition to a more intensive level of care is recommended for the individuals whose dimensional drivers have not improved despite an adequate dose of care at the current level of care, or whose issues have worsened. Transition to a less intensive level of care is recommended for individuals whose dimensional drivers have been addressed, but they can be safely and effectively treated in a less intensive level of care. You can go to the next slide.
Okay. Just taking a look at the time, we're coming up on time. So for those of you, just to let you know, if you want to hang on as we go over some of the questions, feel free to. You do qualify for the CEUs now at that 2 hour mark. So you don't have to stay on, but if you would like to stay on, feel free. There's some questions that we're going to jump in and start addressing. There's a question that
What,
came in
can I just
around,
finish the
yeah,
last slide really quick?
yep.
It's just a reflection slide. It's very short. So the reflection and final thoughts. Take a moment to think about your thoughts, attitudes, and behaviors regarding addiction treatment. Reflect on how your current practice aligns with the settings you work in and any challenges related to staff, services, training, or managed care. Are you in complications-driven setting where the providers may not fully understand addiction and focus more on treating the complications rather than diagnosing and addressing addiction itself? Are you in a program-driven environment where the focus is on having patients comply with a standardized treatment program based on a predetermined length of stay rather than individualized care? Or are you in an outcomes-driven model that emphasizes individualized treatment plans are crafted uniquely for each person based on their clinical needs? As you reflect, recall the guiding principles of the ASAM criteria that we discussed and consider how you can build on your current practices or adjust your approach to better align with these principles.
All right. We'll address some of the questions and then possibly the ones that we don't get to, just due to time. Maybe Megan and I can send out a summarization with the resources when Callie sends out the PowerPoint slides. So there was a question, Megan, that came in around the understanding of a standardized treatment plan as the golden thread format. And oftentimes when working with UR and insurance providers, they have consistently said the golden thread is the go-to. So technically what Megan and I spoke about the entire presentation is the golden thread without using that specific terminology, because the golden thread is essentially saying that from the time of admission through discharge, as we're assessing patients' needs and risk and problems and diagnoses, that is reflected in the plan of care throughout. It's reassessed throughout, and that we're building out a treatment plan that's incorporative of that. So when you have like a treatment plan, you have a treatment plan note, we should be able to see from your clinical note exactly what you targeted with the patient on that particular treatment plan. That's the golden thread that it threads throughout. So if a patient, I'll give another example outside of clinical, patient comes in and they say they have hypertension or medical needs. Is that then monitored? Is there a plan on the treatment plan for that? Can you see the golden thread in the therapist notes and follow up? Do you see it in the nursing medical notes? And to Megan's final points, do I then see aftercare that is specifically going to address those barriers and risks that the patient's identified? So the golden thread is just essentially saying that it works through the entire treatment process. There's nothing better in a golden thread to be individualized to the patient. And Megan just kind of touched on that in the last two slides around it's individualized, it's documented, there's follow through. And if a patient isn't making progress in an area, that we have a process in place of documentation to kind of update that throughout. So we are essentially describing the golden thread. There's another question, Megan, that came in around treatment clinical notes. Person's professor regards their notes as very thorough, perfect, and appropriate, that they're great, but oftentimes their supervisor is saying they're too much of a narrative. They're asking, do we have any advice for writing the perfect clinical notes? I will tell you, when I train teams, I train on less is often more. But what I mean by that is if I'm in a residential facility and we have a treatment plan of care, right? And we look back to those specific examples and we said what we were going to do with the patient, right? We said what the patient was going to work on. We said what we're going to work on to support them. My note should directly reflect what part of the treatment plan we worked on, which often I can see done well in a few sentences. What did we do? How did the patient respond? What is their progress? And is there any follow-up necessary? If there's anything in that conversation, we'll often say if there's something that a patient said or anything specific that was presented that you feel that would be valuable for the note, to tuck that into the note. And we do outcome assessment scores in the notes. But we typically do say, write your note as concisely as possible with the requirements. And we often say that because majority of therapists are struggling with time management and saying that they don't feel like they have enough time. So we're teaching that and then concurrent documentation. We do have some examples of notes, if that would help, or maybe I think in that case, asking your supervisor, maybe to provide you even an example of exactly what they're looking for. And that might help you to be able to kind of determine the follow-up you think that you would want to take. I'll go to this one, Megan, for you. What if during an assessment, a consumer reports they are not prescribed any psychiatric medication, but their progress notes from their physician or hospital discharge summary states the opposite from what was reported by the consumer? Do we include what the consumer reported, or would you go by the physician notes?
So that is a great question. So you're going to take into consideration what was provided on those summaries. That is your opportunity to obtain collateral from that provider. With the member stating that they are not on any medications, this is your opportunity to document what they're saying. And then this is considered as like not being med compliant. It's an opportunity to provide education. And then an opportunity to paint the picture to the insurance company that they need additional education. They need to develop a daily routine to remember to take their medications. But documenting that the member is not med compliant is very important.
Mm-hmm. Okay, great. Thank you. We got another. Go ahead.
I would like to address the one about homelessness.
Sure, go ahead.
This one is really important because being on the UR side and working with the third edition, I have been told many, many, many times that homelessness does not qualify for additional time. Homelessness is addressed differently in the fourth edition, now playing a significant role in developing treatment plans. Recognizing that a lack of stable housing at discharge can directly impact a member's recovery success. The updated ASAM criteria emphasizes a patient-centered approach. Unlike the third edition, which did not consider homelessness as a qualifying factor for continued treatment, the fourth edition acknowledges that discharging a member, let's say, back to the streets, may not support that long-term sobriety. This shift reflects a commitment to equipping individuals with the resources needed to maintain recovery. So that was a great question. And I'm so happy with the changes in the fourth edition. When we said patient-centered multiple times, it truly is patient-centered.
No, great. Thank you for addressing that. Another question we got was, is the GAD and the PHQ-9 the only two used in assessment? Absolutely not. There is a wealth of assessment options and opportunities. You can feel free as an independent provider or within your programs and facilities to choose what those assessments are. The main ones I can speak for our organization is every single patient is getting the brief addiction monitor, which is a 17-item rating scale for any patient coming in with primary substance use, and that allows us to monitor their progress throughout treatment. It also allows us to track like outcomes. We use the GAD-7 for anxiety. We use the PHQ-9 for depressive symptoms. And then we also use the PCL-5 for the PTSD symptom rating scale. So again, that is your choice, what you feel is most helpful, but they should be integrated as their symptom rating scales. I think is a great way to explain it to our teams. And essentially, when we're looking at treatment planning, we are targeting symptoms and behaviors. And we're looking for those symptoms to, improve, right? and behaviors to decrease as we're teaching skills and providing them like appropriate follow-up. So no, those are not the only two. Any other questions that stood out to you, Megan, that you want to try to touch on for a few minutes?
Let me see.
I can give you this one because I know you're working on it within our organization. One of the questions was, we're still using the previous ASAM and readiness for change. Is there a timeline for when you need to switch over to the newer version?
This is a great question. There will be a timeline, but that also falls based on your contracts. So you need to look at the payer contracts and have those updated to be able to completely transition to that ASAM fourth edition, because within the new ASAM, there's also new levels of care that you need to ensure are on your contract. So you'll need to work that out with the payers, but they have started transitioning. Optum was the first to transition.
Okay. We also got a similar kind of question around, and we're actually dealing with this with ourselves at Promises, around some have not fully transitioned to the new ASAM criteria. So asking like, has anyone else struggled with some insurance rolling out the new ASAM levels and some not? The program that particular person's working at is a little hesitant in fully changing our paperwork with all the insurance agencies, like not yet being changed yet. So what are our thoughts around that? And that's something like Megan and I are actually currently tackling together with different disciplines within our own organization. So we put together a work group that includes like managed care and contracting and clinical and compliance. And we started meeting regularly to start to figure out like how our organization is going to be 100% compliant. And the way that we're choosing to do it is we're going off the most stringent. So we have a payer very soon that is coming up on the fourth edition has to be implemented. So we chose to target that date because it'd be more confusing for our teams to be on separate ASAM dimensions, and we had to update our documentation and our EMR, and you have to train all of your teams and things and so on and so forth. So that's just how we kind of took it into consideration. But yeah, that we agree that's a tough one. I'll turn this one over to you, Megan, because you have helped the clinical team significantly. And how long should it take to complete a proper ASAM with writing the information, that's necessary, but in a concise manner?
I mean, it should be, again, individualized. So the time frame will be different for each person. But once you fully understand the ASAM and the scoring, it should not take very long, because you're going to score where they qualify, and then you're going to add a supportive statement for each dimension. It could be 1, 2, or 3 sentences long, but you just need to back up that dimension with why you're stating they need to be in continued care or a higher level of care.
All right, and maybe we'll go ahead and end on this question. This particular person works in an outpatient setting. They added a step down section to the discharge summary. So if someone is stepping down, what do payers look for when viewing charts in relation to the step down?
A step down within the same organization or to a different facility, they look for the aftercare plan. Is it appropriate? Have the appointments been made within 7 days of discharge? Does it meet the members' needs? Where are they going is really important. So they're just looking that the appointments are made within 7 days and it's an appropriate level of care.
Okay. And I'll actually do one more, just to wrap it up. We're trying to get to all of them, sorry. If a client scores out of my program at intake and the client is still admitted to my program, what should I do? So patients need to be in the program that they're scoring for medical necessity. So we have been in situations before where we had to refer patients out to the appropriate level of care. I don't know if you want to add anything to that, Megan, but that's typically how we're working through that with the clinical teams.
Yeah. So when addressing the scoring out of that level of care, we're going to use PHP in residential for an example. Can their needs be met at PHP? What specifically are they scoring out of that needs to be in a higher level of care? So PHP, medically managed and medically monitored. Residential is a 24/7 level of care. There's staff there at all times. So really looking in those dimensions to see what is taking place and what needs to be addressed will determine if they're staying or going, because working with the payer, if the partial setting may feel like their needs cannot be met, but they'll say, but the member is not a risk to themselves or to the community. So why are you recommending them to residential? So it really depends on which dimension they're scoring high in and those drivers for that level of care.
Okay. I'll just do one more because I'm trying not to ignore any of the questions just in case those of you that have hung on, and thank you for that. One of these questions is yours and you're waiting for the answer. How can we get family friend involvement without a release of information sign, even if the person is requesting it? We have to have an ROI to be speaking to the families. Something that I often talk to the clinical team about is we have that as a clinical issue on the treatment plan, and we're trying to work on whatever those specific barriers are with the patient that's in our care that is creating that barrier, or they're refusing of signing the ROI for that particular family member. So we just really work as a team on education and trying to figure out what is the reason why, you don't want us to involve mom and dad and you're going back to home with mom and dad. So we really try to, decrease some of those barriers and that resistancy through treatment. And that can definitely be a tough one. But we have to work with the patient to get them to sign that ROI so we can move forward in the communication. And I think that's most of the questions. So thank you for your time today. Thank you for all of you that have hung on after for this Q&A section. We really appreciate. We'll make sure we send you the resources. Callie will send our follow-up slides. And we're really happy to spend these last few hours with you. And if you have any questions, you can contact us at pbhu@promises.com. And Megan and I would be happy to follow up on anything else that we might not have got to in the Q&A. So thank you all and have a wonderful afternoon.
Thank you both. That was great. And yeah, just a reminder that survey will come out in the next hour or two. Please make sure that you receive it by the end of the day. Let me know if you don't receive it, and then fill that out by next Friday and register for our November webinar with Trish. I'll send that out with all of these great resources and the recording next week. Thank you all. Have a great weekend.
Thank you, everybody.